There's a number of factors that we take into account when we decide which adjuvant regimen to use, and these would include the nodal status, the tumor size, the hormone receptor status, specifically. For patients who have small tumors that are node negative, there's been great efficacy results from a phase 2 trial looking at Taxol and trastuzumab in these patients, 12 weeks of weekly Taxol with a year of trastuzumab. The 7-year disease-free survival from this trial reported by Sarah Tallaney was 93.3%. So that's a very acceptable regimen for patients who have small tumors that were lymph node negative. Specifically in that trial, the tumors were less than 3 centimeters. Residual disease after neoadjuvant therapy is an important prognostic factor. We know that for HER2 positive patients, the amount of residual disease after their neoadjuvant therapy correlates with their prognosis and risk of distant recurrence. I don't use that specifically to determine which regimen to use, because in those patients, they've already received their neoadjuvant chemotherapy regimens. There are some patient factors that I would take into account when thinking about which regimen to give a patient. Specifically, what is their cardiac risk? So we know that women who are older and who have cardiac risk factors may have an increased risk of cardiac events if an anthracycline-based regimen is used.
So I think that one can use the same criteria for both those decisions, because it really boils down to how much risk does the patient have. If the patient has started with surgery, then I think you use the standard staging criteria. You use lymph nodal involvement, I think, is the first and most important. And for node negative, then I go by tumor size and grade. And generally, a tumor that's higher grade and more than 1 centimeter, I think the risk is high. There's going to be those gray areas. I think, for example, a patient with a 1 centimeter tumor, grade 2, I think that could be a wash. But someone with a 0.7 grade 1 hormone receptor positive, I don't think there's much to be added from pertuzumab. So I think that that's the guidance I would use. Now, I think that the decision about using pertuzumab and neratinib are not necessarily independent or either or. You could potentially use both. Now, we don't have much data, of course, because the Extenet study really was in the pre-pertuzumab era, and all those patients received trastuzumab. That was the requirement to go on that study. But that study showed similar findings as do most, and that is if the study is positive, the absolute benefit is going to be greater in patients that have higher risk features to start with, either residual disease after neoadjuvant therapy or positive nodes, larger size, higher grade. So if one is using pertuzumab, for example, as the antibody added to trastuzumab for very high-risk disease, let's say for positive lymph nodes, then it would stand to reason that following the completion of antibody therapy, which is typically when you'd start neratinib, that patient would be a good candidate for neratinib as well, because they still have a higher residual risk. Now, this is assuming that there isn't an interaction between pertuzumab and neratinib, that if you for some reason received pertuzumab and had a better outcome, that all of a sudden that negates the benefit of neratinib. There's no reason a priori to expect that that would be the case. So I think that those are independent decisions. Think the patient is high risk, they can get both. The Extenet study that you will hear about in more detail later did suggest that the benefit was higher in hormone receptor positive disease, and that some may assume that that can be used as a decision point for treating patients. And that may be the case, but I think if you look at it rigorously, and the statisticians will tell you that the study wasn't designed really to look specifically at that, so I don't think we should routinely be using that. But the important point to make here is these are independent decisions. You could either get neither of the additional HER2 targeted therapies, or you might be recommended for both, or you might sort of be at the midway point where only one of them is used.
Based on the Neosphere data, I use a regimen with Based on the Neosphere data, I use a regimen with trastuzumab, pertuzumab, and chemotherapy in the neoadjuvant setting, specifically for patients who have node-positive disease, who have tumors larger than 2 centimeters, who present with locally advanced disease or inflammatory breast cancer. In the adjuvant setting, I would consider using pertuzumab in addition to trastuzumab for patients who I perceive to be at a higher risk of recurrence, specifically if they were estrogen receptor negative and had multiple lymph nodes involved with their tumor. Based on the Extenet trial, The patients who would seem to benefit the greatest from adjuvant neratinib after completing a regimen of adjuvant trastuzumab for a year were those who had high risk of recurrence, specifically node-positive disease and hormone receptor-positive disease. So I would consider using it in a patient like that.